we have a couple other ways that we can target the bacteria selectively in some cases. Uh, yeah, so let's look at if you want to elaborate on some of those.
Yeah. So, for example, the inhibition of DNA gyrase. DNA gyrase is simply a topoisomerase, and a topoisomerase is an enzyme that prevents the supercoiling of DNA because when an enzyme like DNA helicase unwinds DNA, it often gets forms supercoils, twisting the DNA, which puts strain on the DNA. So you want to avoid that as much as possible. However, stopping the action of DNA gyrase can cause damage to the DNA in the long term. So
Yes, also having a lot of supercoiling means that you have very low accessibility to the DNA with transcription factors, and the bacteria wouldn't really be able to transcribe any of the necessary genes and proteins that they require for their functioning. So in this way, the drugs that we use here are fluoroquinolones, such as ciprofloxacin.
quite a difficult one to pronounce. And
Yeah, it's quite difficult.
RNA polymerase
Ciprofloxacin.
level.
Ciprofloxacin. Okay.
RNA polymerase level.
Yes. So at the RNA polymerase level, you have drugs such as rifampicin. So this binds to your RNA polymerase and it sterically hinders it. So it alters its conformation and inhibits it to really bind and transcribe the DNA. So you're basically stopping bacterial transcription from taking place, and the bacteria can't form any proteins or form any proteins that we need for its normal functioning. You also have things at the cell membrane level. You have your polymyxins, so B and E. These are really for your gram-negative bacteria, for the fact that the gram-negative bacteria have an outer cell membrane and an inner cell membrane. So you're able to target with these polymyxins the cell membrane because it's binding particularly to LPS, which is a residue that's expressed on the outer cell membrane. It's known as the bacterial endotoxin, and lipophosphate polysaccharide. So these are cationic peptides and they act as detergents. So they'll break down that membrane. They usually form kind of a barrel structure to allow ions to just pass through, putting osmotic pressure onto the cell and yeah, eventually rupture and break down cell membrane and then the bacterial cell will die.
Okay, just wanted to clarify earlier for the rifamycin. So there are three types of RNA polymerase. The first one mainly transcribes rRNA, second one mainly mRNA, and the third tRNA. So which type of RNA polymerase would rifamycin target?
So I mean, rifampicin isn't really the most selective drug, so it could really easily bind to all three. Yeah. So mainly RNA polymerase 3 is the main polymerase in bacteria. That's the one that you're most likely going to be inhibiting. The other ones as well, probably to a lesser extent. Still, yeah, RNA polymerase 3 is the one that's mainly transcribing and forming your protein products.
Okay, so now into protein synthesis. This is going to be very important. The difference between 70S, 80S ribosomes versus 50 and 60S in bacteria, there are 60S.
So yeah, it's quite confusing to get your head around this sometimes because the bacteria have 70S ribosomes, eukaryotic cells have 80S ribosomes, but the 70S ribosome is composed of a 30S and a 50S subunits, whereas the eukaryotic one is 40 and 60. So it doesn't really add up. But these are yeah, it's just to basically to the size of this protein product. So this gives us a selective target, the differences between prokaryotic and eukaryotic cells. You're able to target the different ribosomal structure. So protein synthesis really comes down to four phases, and it's two of these phases that you can really target. So you have first have initiation, then you have elongation, termination, and recycling. Initiation first starts in the bacterial cell when your mRNA comes in contact with the small subunit, so the 30S subunit. You have your initiator tRNA, which is F-met tRNA, so that's your start codon, and this will bind to your P site. It's the only one that really binds to the P site because TNAs come in and they bind to the A site. Um, okay, so they bind to your A site. Um, then they will associate with the 50S ribosomal subunit to form your initiation complex. And yep, so the initiation complex will then go for further elongation. You have things like initiation factors that are also present here, and you have elongation factors coming in that allow the ribosome to move along. You have oxa, oxazolid, oxazolid, ox, oxazolidinones. Oxazolidinones, sorry, I don't know the name because I know the main drug in this category, which is linezolid, and these bind and inhibit the 50S subunits from binding and attaching to the 30S subunits. So what this means is that you cannot form your initiation complex to start transcribing, to start the translational process. Um, yeah, so in the next step, you have elongation, where you have your amino acyl tRNAs coming into your A site, and then your codon will be read, and the complementary sequence, the anticodon of the tRNA will bind, and then you will start forming a peptide bond here between the two amino acids, one in the P site and one in the A site. You have drugs that you have quite numerous amount of drugs that act at this step, and I think the biggest class here is your aminoglycosides, so genta and streptomycin. What these actually do is they cause slippage in between the ribosome and the mRNA, and they also alter the proofreading capacity. So you have incorrect binding between codons and anticodons, especially from the slippage as well. So you're incorporating and you're forming an incorrect amino acid sequence. Now, you can think the same way as frameshift mutations, this will have a big effect on the polypeptide chain, and you form a large number of mistranslated or non-functional proteins. And what this means is, especially if you have structural proteins that are going into the cell membrane, into the cell wall, for example, uh, it means that you will start having lots of cell membrane dysfunction, rupture, and yeah, so these are really bactericidal drugs, whereas a lot of these other drugs that are inhibiting protein synthesis are more bacteriostatic, so if they can't output more proteins, then they can't grow, but that doesn't mean that they die. So here also you have tetracyclines that act at some of these stages as well. These are important because they don't allow the tRNA to leave. They bind to the exit tunnel of the 50S subunit, and they inhibit the tRNA from dissociating, so you cannot cycle through these three steps of moving between the A, the P, and the S and the E site. So if you cannot get the cycling, you can't keep translating your protein chain. And these are really your erythromycin, your clarithromycin. Now, as I mentioned, you need your ribosome to move along the mRNA, and this is done through elongation factors. So you can also use things like fusidic acid, which bind to elongation factor G, to stop your ribosome from being able to move along the mRNA sequence, and therefore you're not able to translate your protein. Yes, so the last class of drugs I'm going to mention is your tetracyclines, and these they bind to the 30S subunit of the A site, and again they stop that elongation, but from a different side. So it means that you bind to the A site, um, to the 30S part, means that of the small subunit, then it means that your mRNA binding site that would be there to keep cycling through and bringing in your new tRNAs is unable to do that. So you're unable to form any polypeptide chain and transcribe, translate. That was really everything I had covered. We've really looked at all the different targets you can to selectively try and hit the bacterial cell rather than the human cell, which is what antibiotic, especially and all of the chemotherapy is trying to do this selective toxicity where you're only toxic to a certain type of cell. Yeah,
Absolutely.
I think it's also I'll also quickly mention in the closing minutes the fact that you also have termination of transcription and then of the recycling of the ribosome as well, which is really just the releasing of the amino acid chain and then and all the factors that are associated with it, and then also disassembly of all your initiation complex back into the 30S and 50S subunits. So thank you very
A
much.
16-year-old girl presents with a sore throat, fever, and difficulty swallowing. Physical exam reveals enlarged tonsils with exudates and tender anterior cervical lymphadenopathy. No cough or nasal congestion is reported. So, I want to see what is the diagnosis here? What are we looking at? What are some signs you look out for? What are some typical things you see in this very simple, it's a little quite tough question, actually, very limited information. And what kind of treatment you would be interested in?
Let me just look at the case. Uh, yeah, so this is some sort of pharyngitis, unable to swallow, increased temperature, most likely some bacterial or viral infection here. The lymphadenopathy. Yeah. Okay, so I would probably say some form of streptococcus or staphylococcus are really the main ones. I think maybe it might be streptococcus over staphylococcus. The treatments here are quite straightforward. You'd probably give some of your cell wall inhibitors, so penicillin V or amoxicillin. These are gram-positive bacterial wall inhibitors, especially penicillin. Amoxicillin would be your first-line treatments for that.
Okay.
And yes, streptococcus is quite amenable to to beta-lactam antibiotics. Positive
Okay.
leukocyte esterase
So,
and nitrates.
esterase and nitrate. Okay, so what is the pragmatic prognosis here? And what would be the proactive prolonged treatment?
Yeah, so the white blood cell count positive. The fact that it's urinalysis, cystitis, which is a bladder infection, usually, especially because females, they're more susceptible to urinary tract infections. It's probably from some sort of gastrointestinal bacterium. Very commonly, it's E. coli, so UTEC, urinary tract E. coli. And the treatment for this really, let me just look at the vignette again. Yeah, I would probably think it would be some sort of trimethicin, trimethoprim, sulfamethoxazole, that co-trimethoprim. What was it? Co-methoxazole. Co-methoxazole treatment. Um, what was the name of it? Anyway, the combination therapy is quite effective for E. coli in those um, cystitis cases, your UTI infections.
Okay, a 35-year-old previously healthy man presents with fever, productive cough, and chest pain.
Pleuritic chest pain.
Chest X-ray also shows lower lobe consolidation. He is stable with normal oxygen saturation.
Yeah, so in this case, we're really thinking your lobar pneumonia. So lobar pneumonia is very often streptococcus pneumonia. And as I previously mentioned, your amoxicillin would probably be your first line treatment as well. Or you could give things like doxycycline, which are from your tetracyclines, for example, as well, in a nice combination therapy there. Um, yeah, so because your wait, let me look at the case again. So the rationale behind some of these is that your beta lactams, your amoxicillin, for example, are really for your typical bacteria, and you're also able to cover a lot of the atypicals with things like tetracyclines as well. So things like mycoplasma, chlamydia as well can often cause lobar, a lot of these pneumonia cases. So this way you can cover all your bases because you don't know what the bacteria is until you do some form of biopsy or yeah, until you have an idea of what it is in that case.